All right. Good afternoon, everyone. Happy Monday, and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, marketing specialist, and I'll be your moderator. We are excited to welcome Dr. John Burgess as our speaker as he discusses caries removal to increase pulpal vitality, reduce post-operative pain, and increase restoration success. Before we get started, we've got a few reminders for you. At any point during the webinar, we do encourage your participation. Please type any questions you have into the Q&A section of your control panel, and we'll answer them live at the end of the presentation. Henry Schein is not offering CE credit for viewing or attending this presentation live or on demand, and this webinar is sponsored by 3M. Dr. Burgess, thanks for joining us. Take it away.
Thank you very much, Adam. I really appreciate that. This really is my phone number. It's not dial a prayer. So don't wait until the patient's in the chair before you give me a call. But I will take all calls that I can possibly get. My email address is right there. We do a lot of research with a lot of different companies. And so you can see some of that as well. For the disclosure, Schein and 3M have sponsored this program, and I really appreciate their sponsoring the program. I have no vested interest in any product that is being discussed. So I'm totally clear of that. These are some of the graduate students. On the left, you'll see the graduate students, and on the right, you'll see the clinical faculty at UAB that work with us in the biomaterials area, specifically for clinical trials. So we run a lot of clinical trials, and you'll see a lot of these individuals walking around. This is where we habitate when we're doing the clinical trials, and you can see it's a nice facility. It's a sterilization area, and then these Pelton crane units are really nice. They massage the patient and everything else. People want to keep coming in at noon and getting a massage, but no, we try to cut that off. We got video from the x-rays, and that's our clinical research area. We've got 8 chairs in there, and so we do a good job. But here's high caries risk patients, and we all see them. They're all on your appointment book, and whenever their name appears, you go, oh my goodness, I'm going to see this patient again. I got it, because your work is not going to look good. I mean, these patients will accelerate the lifetime of your restorations and make them look pretty bad. But if you'll look right here, this person has a methamphetamine addiction, and that all has occurred in about a year and a half time. So when she started taking methamphetamine, it dries out the oral cavity, and certainly you'll start seeing this caries, which looks like tooth structure. It really is, it matches the tooth, and that is a very rapidly progressing caries. This, on the other hand, is a PhD plus. He runs the IT program like 6 universities. He's an amazing guy. And if you look at him, you'd go, wow, I don't know about this gentleman. He had, his wife had a car accident, killed her and all of his children in one accident. And so incredibly depressed. He was taking antidepressants, et cetera. And there are a number of materials that will diminish salivary flow. The biggest single problem in the adults is lack of caries. That can be from medications, it can be from radiation, it can be from a variety of things. Low salivary flow, problems with oral hygiene, too much sugar. 3 different categories for high caries risk patients. These individuals certainly have radiation therapy, they multiple medications. There are 600 medications that will diminish salivary flow that you can purchase, and it will dry your mouth. When you lose the saliva in your mouth, you lose the bicarbonate, you lose the amylase, you lose the calcium, you lose the phosphate, and you lose the fluoride that bathes the teeth and remineralizes them. If you don't have that remineralization process going on, it is all subtractive. Problems with oral hygiene, that can be mechanical. It can be just no motivation to brush your teeth, and it can also be physical. This is an individual with severe rheumatoid arthritis, and it's very difficult for them to hold a toothbrush, and it is very devastating for them because they can't brush their own teeth. Too much sugar. Too much sugar does not mean I ate a whole pie for dinner. No, it means I ate 6 packs of Oreo cookies while watching television over a 4-hour period. So it is the frequency by which you take these sugar hits that causes the problem that we've got today. And that's high caries risk patients. How caries forms? Well, it forms orally, and initially the tooth picks up glycoproteins from the saliva. And those glycoproteins form a shield or pellicle over the tooth, which is resistant to most bacteria. In fact, it's charged and it tends to repulse the bacteria. So most bacteria can't adhere to the pellicle. The sanguis and mitis are generally the first two in the succession of bacteria that cause caries. So these are the first two, and then they set the environment. It becomes acidic there, and they set the environment for strep mutans. Normally, strep mutans are seen. Strep mutans is an unusual bacteria. It has an enzyme which will ferment sucrose. And if you think that's not rare, it is very rare in not only humans, but also in animals as well. But as sucrose is fermented, lactic acid is formed, and that causes the pH to fall. Below 5.5, enamel begins to dissolve or demineralize. Below 6.2 to 6.5, the dentin begins to dissolve. And so as these things dissolve, you're seeing a subtractive process which causes carious lesions. And that begins with strep mutans in their bacteria called invernase, which really metabolizes the sucrose itself. Well, let's take a look and really see what happens here. And we'll look at it clinically and look at it microscopically as well. And if you look here, these are teeth. And obviously you can see this individual had brackets. And the brackets that are on the teeth, orthodontics, have been removed. But you see the demineralization that has occurred all the way around. Now, plaque forms from bacteria. When they ferment sucrose, it secretes lactic acid, which migrates into the tooth through enamel pores. So it's a subsurface lesion. Let's take a look here. This is the initial lesion that you'll see. This is a restoration. And here we are with the subsurface demineralization. This is wiped out through the pores up here, the undersurface. So it makes a tunnel. And this tunnel then looks like this right here clinically. So when you're looking at the patient and you see this microscopically, you can see that subsurface lesion. If you press hard enough on this, you can actually cavitate these, but we don't want to do it. If you don't cavitate, you have a chance for remineralization. If you do cavitate, remineralization is gone because the structure of the matrix is gone. So let's see what happens. Here is the subsurface lesion itself. And as it continues, we'll get this sort of carious lesion. That's all part of the carious process. The subsurface lesion forming then a cavitation, which continues, and then as it hits dentin, the demineralization process speeds. So calcium and phosphate out is really demineralization. It's at a higher pH on dentin than it is on enamel. So calcium and phosphate back into the tooth from the saliva certainly will cause remineralization. Those are the building blocks of these materials that help remineralize. I say this a little hesitantly, but bioactive materials normally don't have enough calcium. And so if they don't release enough calcium, they will not remineralize. And so you might as well use a glass ionomer rather than a bioactive material. Sorry, but that's the truth. Infected versus affected dentin is a topic that has been discussed since Maury Massler coined the term in 1955. So the histologically and clinically, dentin has two separate layers. These are very difficult to differentiate by simply looking at them. The color is about the same, and as you go deeper, the color of the dentin gets a little bit darker. And so that can fool you into thinking that this area, which is relatively hard or firmer at least, is not carious or is carious. So the outer zone stains, and the outer zone, which is this zone right here. So this is a section through teeth right here. This is the dentin. The whole thing is, this is the outer lesion. This is removed most of the morphology of the dentin itself. The bacteria have. Bacteria secrete enzymes called proteases, and these proteases can really chop up everything that's in the tooth, softening it. Now, the proteases precede the bacterial invasion. So down here, you'll see affected dentin. This affected dentin is bacteria-free or relatively bacteria-free. I know a lot of people like to put all kinds of antimicrobial agents here, but I'm not real sure that that's going to be helpful in this case. Outer carious lesion, inner carious lesion. The inner, if you look at the hardness of this, normal caries, normal dentin has a new hardness number around 60. If you'll look down at demineralized dentin, you can get all the way into 30. We actually section through teeth and use a hardness tester to determine where we are and where the dentin is softer. It's softer in the outer lesion, more firm in the inner lesion, and then you hit solid tooth structure up here. So you can see how that gets firmer as we go deeper through the carious lesion. Outer is softer, middle is in between, and then normal sound carious. So a normal sound dentin is not carious. There are different ways to treat the high caries risk patient. We will go through this very rapidly. We do a caries risk. I'll show a caries risk assessment form. You can request that from me, and I'll be happy to send it to you at any time. You can assess the patient that way. We use chlorhexidine, not because it prevents caries, because it really doesn't. There have been a number of studies which show that, and then the meta-analysis showing that chlorhexidine, even at the 40% level, does not really reduce the bacteria that cause caries. So why do we use chlorhexidine then? Well, we use chlorhexidine because it will remove the bacteria that cause gingivitis. And we've all tried to restore a tooth where the soft tissue is grown up around the tooth, and you touch it and it bleeds. You look at it and it bleeds. And so that blood can be incorporated into your restoration, reducing the longevity of the restoration. Caries control, we're using resin-modified glass ionomer. The highest fluoride release and recharge is with the resin-modified glass ionomers. They do not release calcium. Some release strontium, but not calcium here. Remineralization, MI Paste Plus is very good. MI1 is a little bit better. MI Plus is a toothpaste sort of, and then the MI1, you can paint that directly on the teeth with your finger if you want to. Clempro 5000 from 3M also has a bit of calcium and phosphate in it. So amorphous calcium phosphate is there. The carie-free system is xylitol, fluoride, amorphous calcium phosphate, and then it also has a bicarbonate just like the saliva, which helps buffer and elevate the pH. A remineralization really is dependent on fluoride and the calcium. If you don't have calcium, you don't get remineralization. And fluoride just takes the calcium from the saliva and puts it right back into the tooth. We reevaluate these patients every 3 months. If you don't, they lose their enthusiasm and you've lost that patient. So the risk factors, yes, sucrose intake is a problem. And a lot of people have really high sucrose intakes. But the biggest single problem with the male or with the adult is the reduced salivary flow. Medications, therapy, more medications. And so these can, or poor oral hygiene can also cause reduced salivary flow because the plaque is different. Minimal intervention dentistry, that's essentially what we're talking about here. And we've shifted away from, I remember when I went through dental school, if you didn't get rid of every little molecule of carious dentin or softer dentin, you didn't pass the practical. And that was a big deal. Well, I'm going to show you study after study today that shows you don't have to do that. You can leave caries there and it has zero effect on the restoration, has zero effect on basically on the pulp. If you take everything out and expose the pulp, you got a lower success rate. There is no ifs, ands, or buts about it. If you look at this, what the main goal is to preserve pulpal vitality. We want to remove the infected caries, but preserve the affected dentin. This now is our caries risk assessment. If you'll look, it has a lot of factors over here. It is a one-page form. You can put it right in the record, and you check these little boxes off. You know whether the person generally is high caries risk or not. This is what you give to the patient if indeed they are a higher caries risk patient. You just check it off, hand it to the front desk, and they can go ahead and give out whatever you want to give out. And then you reevaluate these patients over every 3 months. This is an individual that I saw not very long ago as a patient in Alabama, and she was there, and I looked at her and said, hey, her soon mother-in-law to be wanted me to look at her teeth. And so I looked at her and said, well, okay, but we're in the business of putting fillings in and watching them fall out or break or whatever. We're not in the business of putting restorations in and watching new caries form around them. So anyway, I said, well, okay, let's look at her. And I looked at her and then decided, well, okay, let's give her some toothbrushes and some dental floss and show her how to use these things. That's incumbent on you. You as the dentist have to make that little spiel to the patient. If you don't, the hygienist has influence, but the dentist has more influence on the patient's hygiene. And so she started brushing her teeth, and she kept feeling her teeth with her tongue. And I'm going, what's going on? She said, my teeth feel smooth. It dawned on me at that point that she'd never used a toothbrush, which, there are people like that. Minimum intervention therapy. If you'll look at this is absolutely the wrong way to do it. This is absolutely the wrong way to do it. True, the margins are clear. And that's what we want. We want sound margins all the way around this preparation. But we do not want to go to the very center of the tooth and remove the caries. You can leave that center right there without removing it. You'll have fewer exposures. You'll have much greater success and less postoperative sensitivity when you don't expose the pulp. Now, there are different ways to remove caries, and this is taken off in Europe, and certainly they really do talk an awful lot about this, complete versus stepwise versus partial. Complete caries removal, I get in with my spoon excavator and I go down to the hardest tissue and then a little bit more. And so that's the way I was taught as a dental student, and that's not really correct. Stepwise caries removal means you take out some of the decay, seal it up, wait for Dr. Stanley's 6 months for the undifferentiated dental cells to change into an odontoblast, and it will then lay down dentin. So a lot of times we jump back into these things too soon. Now, 6 months is about what you want to wait if you're going to do a stepwise removal. So there's two removals, not just one. You remove part of the decay, and then you come back in 6 months later, remove the rest of the decay, and hopefully it's laid down new solid tooth structure, and you don't have an exposure. Well, no caries removal or partial caries removal means I take out decay and I seal in the rest of the decay in the center of the tooth, or the lateral walls where I expect an exposure to be there. I stay away from that, and we seal over that. The calcium silicate type materials are really quite good with a high pH, stimulating new dentin formation in here. No caries removal. That's how this whole thing started. No caries removal. Handelman and others started off by sealing caries via amalgam into the tooth. They put a sealant over the top of the amalgam, and yes, the sealant would then fall off of the amalgam ultimately, but it's sealed all the way around the amalgam. Same thing with sealant. So when these were really looked at, really looked at separately, these different techniques, the pulp will be exposed with complete caries removal in 347 out of 1,000 teeth. The stepwise removal, 154 out of 1,000 teeth. When partial caries removal was done, 50 out of 1,000. So be careful. Deep caries, it's difficult. I understand. And a lot of times you're trying to get, well, I can just get one more spoonful out, and you take it out, and what's underneath it? Well, it's the pulp. So there are problems to removing all the caries. And if you look at the data says lower bond strengths with deep dentin. The closer you are to the pulp, the more tubules you have, and the weaker that dentin is, and the more it leaks. That's deep dentin, significantly lower shear bond strength, tensile shear bond strength. So total etch adhesive may lead to more MMPs. So the proteases, which are in those areas, are released. The deeper you go, the more proteases you get. The deeper you go, the more proteases you get. So here we are, MMPs increase from superficial to deep dentin. The deeper you are, the more proteases you're going to release. The more proteases you release, then the more it destroys the collagen down there and weakens your bond. So this is superficial dentin. See the space in here? Can you bond to that? Of course. This is now deep dentin, and you've got so many tubules here that it's very difficult to maintain the strength of the dentin. So that's what we're trying to do, is maintain the strength of the dentin. This little study right here looked at this and said, hey, let's go ahead and remove completely, do a stepwise evaluation. That's 2 visits, 6 months apart. A partial caries removal, so you remove part of the dentin caries and then seal the rest of it in, and then no caries removal. Less pulpal damage when all or some of the dentin was left behind. No difference now get this, no difference in cold sensitivity or postoperative pain in any of those techniques. So you'll get no postoperative sensitivity like you think you would by removing all the caries. Okay, so here we are, the Cochrane group, the statistical group, which evaluates and does meta-analysis. They took 8 studies, put them together with 934 patients. Over 1,000 teeth were included here. Removal of caries has disadvantages. Why? Well, it can cause pulpitis. An exposed tooth has 20% less success rate as a non-exposed tooth. Postoperative pain, yeah, sure. And in weakened tooth structure, the deeper you go, the more of these MMPs that you release, which weakens the bond and weakens the tooth structure. So stepwise and partial excavation, reduced exposure versus complete. Well, we've said that several times now, but I think it was worth repeating. The stepwise and partial excavation reduced the risk of pulpal exposure. Insufficient evidence to determine whether it is necessary to go back in and remove the remaining caries that's there by a stepwise technique. Partial caries seems to be the best way to go. And I'll show you some backup on that one. Here's partial versus complete caries removal. Selective removal now, 1 visit, selective removal to soft dentin, where soft or leathery dentin is left close to the pulp and sealed beneath the restoration, is recommended for deep lesions. And that's one very prominent investigator is out of Germany. Partial carious lesions removed, restored in a single session, yes. 99% in the partial dentin removal, the partial caries removal, 86% when you go back in. A lot of times when you go back in, you'll find that you have an exposure because you get a little bit aggressive, and then reopening, you don't have to remove the caries. Just seal it, leave it. It's going to work. Now, there are some exclusions here, and we'll go through the success rate at 18 months. This is going to be at 5 years now. I went back. There are 3 articles on this, one at 18 months, one at 3 years, and one at 5 years. But it's all the same group of patients using the same investigators to follow these. So stepwise excavation, this is now at 18 months, partial caries removal, 99% success rate at 18 months. 86% when you stepwise removed. You removed partial, 6 months later went back in and removed it again. Now, at 5 years, 80% success rate in partial caries removal and 56% in the stepwise group. The study supports using partial caries removal as a single visit technique to manage deep caries, no doubt about it. Stepwise partial caries removal versus complete removal, another author, another study at 5 years. 5 years is pretty long term. There's 314 teeth that were involved in this, and at 5 years, they had 76% recall at 5 years. Stepwise removal, higher success. And that was 60%. So it's lower than the one before, but I'm trying to give you a cross-cut of everything that's there. At 5 years, yes, it falls, but there it is. At caries removal to hard dentin, 46%. So you drop almost 20% right there. So after pulp exposure, and this is a Swedish author, so after pulp exposure, only 9% were successful. That's the only one I've seen that says something like that, but that's what he said. A systematic review to compare long-term deep caries with permanent teeth with partial caries removal. Outcomes for 426 permanent teeth. Now that's a lot of teeth. 88% at 2 years for both techniques were reported. So they showed no difference in partial versus stepwise technique, but they both were success rate. The restorations were successful at 88%, and then pulp vitality was 96% at the end of 2 years. Pretty good. Another one, stepwise caries. You just thought there were a few studies here. I'm trying to give you a cross-section of all the studies that I could find here. Tissue removal, carious tissue removal versus non-select. Non-select means I just go in and blindly use a round burr and take out everything that I can. Stepwise removal, significantly greater success, 62% compared to removing to hard dentin at 46%. And that statistically was different. Okay, these are the caveats. This area has to be cleared. This area, the gingival area, must be caries free. This must be caries free. We've measured the depth of these preparations, and they run around 5 millimeters here, sometimes 6. Isthmus widths are very smaller. These look like a very conservative preparation, but unless you have a bit of an undercut here and a bit of an undercut here, I've seen way too many of these things fail. I call them C preparations, and they do come out. The adhesive by itself will not bear the load of occlusion unless there's some support here and here. This is exactly what I would like to see. All caries removed, sound margins here, and then sealing that in very carefully. And that works well. Again, here are some of these C-type things. Yes, I've gotten some to work. There's no question about it. Here's 2 of them right here. But look at that gingival margin. That gingival margin has to be hard and clear. Here, where the pulp lies, is where you can fudge and get away with not removing the caries. Okay, what happens when you expand the isthmus width and you deepen the tooth? Well, you weaken the tooth. And especially if you go across the marginal ridges. If you go across the marginal ridges, that weakens tooth strength. Here, fracture. Here, fracture. And then there, a fracture. You can see them, and you see them all the time. Preparation size affects tooth strength and restoration longevity. Again, it's been shown. Larson, Paul Blazer looked at the depth, the deeper preparations produced more profound fractures than a shallower, wider preparation. So the depth of the preparation increased that lever arm and caused it to fracture. But a number of people, this is Vail, 1948, the Irish Dental Journal, was the first one to show that 1/4 of the isthmus, if the isthmus width was 1/4 or less, the fracture strength of the tooth was not affected. So 1/4 or less, that means it's a very small preparation. I understand that, but these things do work. This is one reason why they work so well. Here is the lever arm that you see from the cusp tip down to the central groove, right? Okay, so that's a lever arm right there. And the tooth flexes a certain amount as you get food in here. Well, this is now an MOD cavity preparation, and it's been reduced. Here it's from here to here. Here it's from here down to here. And then this is an endo access opening. Well, it's no wonder that endo teeth, endodontically treated teeth, have to be cuspal covered in the posterior. Not in the anterior necessarily, but in the posterior, because the forces, the biting forces are totally different in the posterior. But it is really due, I think, to this long lever arm there. And this is where it fractures, right there. Okay, this is from Wint in 1987, not a new study, but here is an intact tooth. That's how much it took to fracture that intact tooth. This is what happens when you do an endo access only, just the endo access. You break that arch of the dome, and then it weakens that entire structure. This is an MOD only. So you can see just the MOD cavity preparation weakens that tooth significantly. Endo and MOD, well, it's the weakest of all three. And you can restore that strength back by covering the cusp again on posterior teeth. Yes, I treated this individual and this individual as well. If you'll look at this, you can save a lot of teeth and work on them again later on. You really will develop a good rapport with the patient when you're doing this too. But these are hard. These are very difficult. And I'm the first person to say that. Lesion progression, mineral loss is twice as great, over twice, 2.5 times faster in dentin than it is in enamel. Initially, until these cavitate, you can reverse it. After they've cavitated, you cannot reverse it. So what does saliva do? It remineralizes it, supplies the calcium, the phosphate, and it's got bicarbonate in it, which elevates the pH. So if you've got a good saliva flow, what happens after you've eaten something that's caused a lot of sugar breakdown, then you can go ahead and neutralize that by applying a buffer, which is the bicarbonate in your saliva. So stimulated salivary flow, normal, is greater than 1 milliliter per minute. Unstimulated, it's a quarter of that. So if you're looking at stimulated versus unstimulated, basically we just give somebody a little piece of beading wax and let them chew on the beading wax and not swallow, and then they spit out into a little dappen dish, and we measure how much saliva they've got. But in children and adults, there's totally a different view in both of these. Salivary calcium levels are low in children. Children have smaller deciduous teeth, and these have a less enamel covering. The phosphate levels are the same, but the calcium levels are lower. The higher pH, the critical pH, the pH at which these teeth begin to dissolve or demineralize, is faster in children than it is in adults. Fortunately, greater demineralization at lower pH levels are the same. Again, don't forget, it's not just eating at meals. It's the in-between snacks, the Oreo cookies that you ate for half the night last night are what really caused demineralization. Again, here's another one. This is a Scotch-Bond Universal. We've used that and finished up a clinical trial at 5 years on this with non-carious cervical lesions, a 96% retention rate. No mechanical retention on class 5s. But if you look at this one's got a chance of success, but you can see where it's falling apart. But this right here has to be undercut. So you take your burr, 69L, and just lean it this way, go toward the cusp tip. take your burr, lean it this way, go toward the cusp tip, and that will give you enough mechanical retention. This one's in jeopardy right here. This could fracture. Yes, it can. But there's plenty of undercut there, almost too much undercut. Okay, so here's the Filtex Supreme Ultra right there. And if you'll look at this, that blends in pretty well. We're doing a new clinical study where we're looking at 3 different Filtex Supreme type materials, the Supreme Ultra, and then the flowable and the bulk flowable. So caries, to leave or not to leave. Complete, leaving some caries, no exposure. 4 out of 49 studies were evaluated here. This is, again, another one of the Cochrane group. No history of spontaneous pain, no hypersensitivity, and 1 minute max hot and cold. That's how you do this: palpation, percussion, and then cold sensitivity. If it's a lingering, long-term cold sensitivity, be careful, because that one could be going south. Not re-entering, no effect, no adverse effect. Okay, here's isolated caries removal. We isolate these, and I use rubber dam all the time. I know why I use rubber dam. I use rubber dam because it muffles screams from the patient. That's why I use a rubber dam. Okay, so here's a selective caries removal. That's an indirect pulp cap, or selective caries removal. You see, I didn't go here. And if you look there, it looks a little bit like there's a blush there. This is deep as well. Okay, so both of these, no pulp exposure, but we're getting close. So this is biodentin. It's a calcium silicate material. The biodentin is excellent for this. There are other materials that are calcium silicate, particularly the hybrid materials are from Bisco, but this is biodentin. It's from Septidont. Here it is right there. And then here it is at 7 months. If you can't decide if you can restore this tooth, this is the best approach that I know to do that. You build it up with this material. You can put it in bulk, and it polymerizes. And then over a period of time, you watch it. And if it starts to break down, then you replace it. But this is biodentin at 7 months. By the 7 month time, you know that the person's going to have good oral hygiene or not. You know if the person is probably going to take care of that furcation involvement, which is very difficult to do. So at any rate, this is safe. This now is another almost carious exposure right there, but it's an indirect pulp cap, selective caries removal, or what the Europeans would call that. We call that an indirect pulp cap. Okay, here is caries right there. And if you look at this, looks pretty good there. This is an indirect pulp cap, but it's because it's swung around to the lingual. So it looks like a direct pulp cap, but it's not. It was an indirect pulp cap. Here's another one. This is an MOD. The D is fractured out, and there's a crack in that amalgam right here. And so when I took it out, here's the latex rubber dam. And if you look at this, this now has caries. Well, but it's hard. There's no reason to take that out. None, zip, none. Okay, so here's the biodentin placed over it. Now, I got a little exuberant over here. True, yeah. So here's the baseline. This is Filtex Supreme. Again, 1 year recall here. Looks pretty good. This is 3-year recall, and it's still intact. So you can use the biodentin because it's strong enough. It's much stronger than calcium hydroxide, dical. Because calcium hydroxide is in a methyl cellulose base. What happens when your newspaper is on the yard and it rains, or your sprinklers go off? Well, it's very easy to tear those pages. And it's the same way because it's a methyl cellulose base. This is Theracal. It's a Bisco product. It's a resin modified calcium silicate. And if you look at that, this is left. This is left here. See the caries there? We left it here, and we're going to cover it with the calcium silicate type material. There's some controversy about this material, but from everybody that I've talked to, I've not seen a clinical trial on it, and I've looked, but from people that I've talked to, Theracal really is a very successful material at promoting new dentin formation underneath it. So here it is. There it is with Theracal, and then here it is over a period of time. So I like keeping this in. I didn't do it, but I like keeping this in because every time I see it, I begin to grind my teeth. When you look at this, this is absolutely the most incorrect thing that you can do on a tooth. This is exposed right in the middle of the tooth. Look at this down here. What's that? Are you ever going to get the bacteria from here into here? Absolutely you are. And if you look, the margins aren't going to be very good. You're going to get what's called recurrent caries. That's not recurrent caries. That's primary caries that was left. But this really reduces the chances of success for that restoration. In addition, you want to remove everything on the periphery first. You remove all of this first and then take out the center of this. Here's another one, flowable bulk fill, and then different composite resin. And if you look at this, C shape, C shape, here we are. Two of these restorations are over here. And these are the Filtex Supreme Ultra. This is a clinical trial that we've got going now. These look good. And here's the Filtex Supreme. This is the flowable, and this is the bulk fill flowable. So the normal flowable, 2 millimeter depth of cure, 4 millimeter depth of cure here, and then a highly filled composite resin. So very, very highly filled. And so these look at the end of 1 year, not too bad. Looks pretty good. High filler rates on both of these. Don't think that flowable composite resins are the same as they used to be, because the filler load in all these flowables now is much higher. And they found out how to do that by using a different silane. And so over here, this now is an interesting case. This was a gentleman who was in one of our other caries studies. And if you look at this, here he is right there. We're putting in class 5s, and we're made out of Keytec fill, which is a glass ionomer, Titan, which is an amalgam, and Victomer, which is a resin modified glass ionomer. We're putting these in the class 5s. Here he is at 9 months into it, and then here he is at 15 months into it. So that's how rapidly caries progressed in this individual. He liked Dr. Pepper, and he didn't like Dr. Pepper that was diet Dr. Pepper. And so I was watching him one day when he came out of the office, and he walked across the parking lot, and my office happened to look over overlook the parking lot. And here he was. He opened the door and had a coat hanger bent over the window and had a Dr. Pepper right there. So he took the Dr. Pepper out and took a swallow of it. That's a bad thing for 2 reasons. 1, you've got an acid hit, and 2, you've got a high sugar hit. Around 9 teaspoons of sugar per can. If you're using Mountain Dew, it's 11.5 teaspoons of sugar. So you cannot, and you sip these things. You don't just drink them straight down. You sip them, and they are very, very destructive, particularly with somebody else whose oral hygiene is not as good as it could be. These are direct pulp caps. This is calcium hydroxide. This is a dentin bonding agent. And do try to keep your dentin bonding agent away from the exposure, if indeed you have an exposure. Cover it with something, calcium silicate or dical, whatever you want to use, Theracal, LC, it doesn't matter. I put the 1 in these studies, 40 restorations, 2 months, calcium hydroxide, all the way through. Calcium hydroxide beats pulp capping with a dentin bonding agent. That doesn't work. It doesn't work. It kills the pulp. Stay away from bonding agents near the pulp. This is MTA versus calcium hydroxide. This is a practice-based research network study, large numbers in these. And if you'll look at this, mechanical exposures versus, and then using resin-modified glass ionomer. 2 months, they're equal. 2 months equal. And so real time, they both look good. At the very end, though, the current understanding is that MTA is a little better than calcium hydroxide. I think because of the solubility or the leakage. If you get leakage, calcium hydroxide just doesn't work very well. And they both release calcium hydroxide, the dical and the MTA. So if you look, though, equal, 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 and then the MTA seems to be pulling ahead in the more recent studies. This is a Selective pulpotomy. This is where you have a fracture, and you have this fracture, and the pulp is exposed on the lingual. And the patient has not been in to see his father because he was told not to go out rollerblading, and he rollerbladed and fractured this tooth off, and you have a lingual exposure back here, but the father hasn't seen him for 48 hours. Okay, patient comes in. If you look at this, this is a Selective pulpotomy where you take about 2 millimeters of the pulp and remove it with a sterile burr. Carefully remove it, very slowly remove it, and you can get it out. Be careful you don't tear all the pulp out, but you can do that. Now, here we are. We're using glass armor to seal this, and you can see success rates on this are very good, 94, 98, and 100% at 1 to 8 years. Okay, this is 60 months. That's five years right there. I'm sorry, that's almost 2 years, a little over 2 years. Okay, so here we are over here. We've got the tooth. We've got glass armor in because glass armor bonds really well to dentin. We've covered that with composite resin. Now, let's take a look. Over here, what's that right there, by the way? That is a dentin bridge. That's a biologic seal right there. And that's what we want to see. We want to be able to see that. Good apex. The material looks really quite good. So now you can go ahead and restore this any way that you feel like restoring it. And there's the glass armor down, and then we fill the chamber with composite resin. Complete caries removal. Don't forget, complete caries removal removes all caries, exposes the pulp most frequently, weakens the tooth, and lowers the chances of success. So complete caries removal, if you're close to the pulp and you get that radiograph and you look at it and go, ooh, this is a deep one, maybe you need to be a little bit with a softer touch. Stepwise removal, remove caries partially, wait 6 months after you restore it temporarily, and then come back in and remove some more. It doesn't seem like there's any greater success to coming back into it. So we pretty much stopped doing stepwise. We just use selective caries removal. That's a one-step indirect pulp cap. You leave some caries and you seal over the top of it. Leaves caries permanently. Recent research on deep caries supports less invasive strategies, and that's really what you want to do. Complete removal is not necessary on a lot of these materials. And so as we look at this now is a wonderful sunset right here. Beautiful place. Love it. The end. How about that? We finished on time, and we did a quite good job on this thing. And again, I would like to thank not only my graduate students for working with me on this stuff, but also you for attending this. I know it was like trying to get a drink of water from a fire hydrant, but I wanted to cover as much material as I possibly could in as short a time as I had. So that's what we have done, and I'm very happy to take any questions that you got. Question on this now?
Awesome. We do have some questions, so let's get right to them.
Okay.
The first one here, what is the best way to document and inform patient and possible, what is the best way to document and inform the patient and possible different dentist seeing caries under restoration?
Right, yeah. Certainly the best way to do it's in the record. And a lot of people have the patient sign that. What I do is talk to the patient, sit there and say, look, we're going to try to avoid a root canal. And when you say that those magic 2 words, root canal, the patient begins to tense up and get very nervous about that. Well, if you tell the patient before you start excavating caries, before you actually start drilling on the tooth, this is very deep. We may have an exposure, but I'm trying to avoid it. I'm trying to avoid a root canal for you in this tooth. by golly, they will remember that. And so, and I've had a few, not many, come back and say, this tooth is still bothering me. Let's go ahead and do the root canal on the tooth. Okay, that's fine. But they were prepared for it. You led them down that path. You said this might not be successful. These aren't 100% successful, and you're going to run across the few that it's not successful. So I try to do that. I always put it in the record. I just write, informed patient and discussed vital pulp therapy versus non-vital pulp therapy. So just put that in very quickly. And generally patients will accept that and go from there. Yeah. So they're happy.
Great. Is there any recommended, or is there any literature that you would recommend on partial decay removal techniques?
Yeah. Boy. Reddit is one, and that's out of the Cochrane report, and it's a variant. But if you read something on the Cochrane report, don't do it when you're tired because it will put you to sleep. I promise. It's a little intense literature. Handelman, who was one of the very early people who started sealing things without removing caries, and by golly, the Metz-Fairhurst as well. So those are if you'll send me your email, I will send you some articles and you can read them. How's that? That's as good as I can do it.
And what's your email again so I can put it in the chat? Yep.
It's jburgess@uab.edu. I'll do it again. jburgess@uab, University of Alabama at Birmingham.edu. And
Great.
That'll get to me.
Thank you. I put that in the chat for anyone that wants to contact Dr. Burgess.
Okay.
All right. Moving along. Is the new Scotch Bond Universal Plus adhesive better than Scotch Bond Universal adhesive?
The new Scotch Bond Universal is the improved version of Scotch Bond Universal. Now, I really like the Scotch Bond Universal, and it's an excellent material. We compared that directly to Scotch Bond Multipurpose, and I've been a Scotch Bond Multipurpose advocate for a long time, and been found that the Scotch Bond Universal was significantly better, more retentive, and it's more retentive because you've got the MDP monomer there, and the MDP monomer bonds chemically to the calcium in the tooth. And it also still bonds micromechanically, forming a hybrid layer. So you got two mechanisms of producing a bond. The new Scotch Bond Universal Plus is a new material. It should be out very soon. We've done bond strength testing to everything. It will bond to ceramic really quite well, even without a silane coupling agent, and if you're using Emax or a glass-containing material. So this material is equally as good, and I think it's going to perform very, very well. Universal adhesives are where the shift is going, and for a couple of reasons. One, it's a single bottle. Two, it's faster to apply and cure. And every step that you have increases your chances for contamination, blood, saliva. And so the faster you can get it on, the better you are for longevity and that particular restoration. So yeah, I think both are going to be really good. The Scotch Bond Multipurpose, we've moved away from that as a school. We've gone to the Scotch Bond Universal, and it really does work well. So post-operative sensitivity with this stuff is almost non-existent. I mean, occasionally you get something, but not very often. So I would strongly recommend that one for you.
Do you recommend deeper caries removal with a spoon, a low speed, or a high speed?
Yeah, there are a lot of ways to remove caries. The Carisol was one way it was put out. There was a chemical way to remove it, and it heated, and then it had a little bit of agitation, which caused the caries to dissolve. But it took about 8 minutes to remove the caries, and people weren't really happy with the time that it took to do that. It's one way to do it. You can use a polymer burr. The polymer burr will not remove anything over a new hardness number of 60. So it will not remove sound tooth structure. And so put that into your slow speed handpiece, and yeah, it works really quite well. It's expensive, but it's still a very, very good concept. Most of the time, I'll remove an area of caries with a round burr and do it fairly quickly. And then I go in and remove things staying away from the center of that tooth, or you're going to get an exposure. And you know you're going to get an exposure. You know what your endo-access openings are, and you look at it and go, okay, I'm not going to go there. I'm going to leave that, go right ahead and bond over it, and it's going to work just fine for you. It really will.
When you do selective caries removal and you say you restore over the deep caries, are you placing a liner before building up with the composite?
Not with a composite. I'm normally putting down the calcium silicate type materials. If it's deep, and maybe you've removed a little bit too much and you see a slight blush, that's 0.2 of a millimeter. You're 0.2 of a millimeter away from the pulp. So that needs something to close down all those tubules that you've got. The deeper you go, don't forget, the more tubules you have. So the deeper you go, the more tubules you've got, and the more interaction you can have. So I put down a layer of the calcium sulfate over it, and by golly, it really, really works. The biodentin is good. The Theracal LC, some people have said that it's a hybrid material, and you got a 1 millimeter depth of cure on that particular material. So you have to layer it, but you don't need big layers. These materials are so much stronger than calcium hydroxide, dical, or Life, or Procal, or any one of those, that this material will hold the restoration on top of it. You won't have fractures. And again, if you need to, you can take the calcium silicate material and put it from the near exposure all the way to the occlusal caval surface margin, and it will hold the occlusion for you. Okay? Not long term, but at least it's 6 months. 6 months is what the manufacturer says.
All right, I've got a lot of questions surrounding sodium diamine fluoride. So I'm going to kind of leave that open-ended for you to go whichever way you please.
Okay. Yeah. The silver diamine fluoride, and I think that's what you meant there. The silver diamine fluoride is a good material. There are 2 products on the American market, and one's out of Florida and one comes in out of Australia. And so it's an excellent material. The only problem that you have with silver diamine fluoride, well, let me back up a little bit and say what's in it. What's in the silver diamine fluoride is ammonia. So it's a high pH, a pH around 11.5. And there is silver and there's fluoride. You've got an antimicrobial substance. You've got a substance that will stimulate remineralization, and you get these silver wires. This material will penetrate close to 2 millimeters down into the tooth. And so that's why you get such good sealing with this material. If you've got a tooth that is a a bit sensitive, desensitization that will really desensitize teeth. Now, it will stain teeth, yes, but it won't stain teeth that are not carious. So if you've got no caries, you can use it as a desensitizing agent. If you have caries there, it will stain that caries black. And I mean very, very black. It's black. And so like asphalt. So that's a problem, but with the antimicrobial agents that you should have, the current literature says apply this every 6 months. So you bring the patient back in. You can apply a whole mouth in about 10 minutes. I mean, it really does not take very long to do it. Your first inkling will be to use too much of the material. And because it's a high pH, it will kind of burn the soft tissue a bit, not catastrophically or anything, but if you get it all over the soft tissue, yes, it will burn that soft tissue slightly. It'll turn it red, but that goes away very rapidly. So I like the silver diamine fluoride. The Riva Star is the one that I'm most familiar with. The Caries Advantage is the other one out of Florida. I'm just not as familiar with that one. But we've also seen in the literature, it says that the results are variable. In other words, you can use the silver diamine fluoride underneath. You can use silver diamine fluoride on the carious lesion without removing any caries, and it will activate and harden that tooth. You can go all the way back from softer tooth structure to hard tooth structure, exactly the same as normal dentin is as far as its hardness is concerned. So it will work really quite well. It's an excellent material at arresting caries. The disadvantage turns carious tooth dark. So if you're going to restore over that, you remove some decay, you've got the caries there, and you put the silver diamine fluoride down, and it turns it dark, you have to put an opaquer or a composite resin opaquer on top of it. That a composite resin opaquer then will mask it out. Caries got a good one. It's called opaquer, and so you can buy that. It's pretty easy. Or use the dentin, the very opaque shades of your composite resin, and put that down as a thin layer, and then restore on top of it, and you won't get a dark show through from the silver diamine fluoride. But you do not have to take caries out. It will harden on top of caries and arrest that lesion. And it's 90% effective. I mean, this material really does work very well. We've lagged behind in the United States about silver diamine fluoride, but boy, does it work. It's an excellent material.
All right. Well, I'm glad I asked about that. Let's see. We're a little short on time here, so we're not going to get to everyone's questions tonight. I've pinpointed 2 more for tonight, but if you do have questions that we don't answer, again, feel free to email Dr. Burgess directly. His email is in the chat for you. All right. So how do you differentiate an occlusal stain at the surface from a real caries?
Yeah, by hardness and texture. If it is very, very shiny, it's probably not caries. It is more like sclerotic dentin. And run your spoon excavator over it. You'll feel as you go down that it will get harder. Or if you're going laterally, occlusal, gingival, occlusal, facial, lingual, mesial and distal. If you're going in those directions and you're starting to excavate it, as long as you've got a margin and go over that margin now very carefully with either a diamond or a slow speed, a finishing burr works really well for smoothing down that margin. And a 7404 burr will do very well for doing that. You just go around it very rapidly, it hardens it, and then you can restore underneath it, and it's going to work out very, very well for you, even if you leave a bit. Even if you leave a bit, don't go hang yourself if you leave some caries there. We've all left caries. Whether we know it or not, we've all left caries. So and it does work. Yeah. One more?
Right. Well, I was going to ask you one more, but you kind of just answered it, so I got to find another one now.
Sorry.
Let's see. If leaving decay, no exposure, when do you use calcium silicate, and when do you just go to dentin bonding?
For most of the studies that we are doing now, we're funded by different companies. And when we do get a lot of funding from different companies, Ivor Clark, Octane Supply, 3M, we get a lot of them. So when we're doing those studies, we normally don't select teeth that have deep, deep caries. And so we'll select teeth that have a little more superficial caries, just a quarter into the dentin itself, and we will remove the caries and then not put anything on underneath it. So you have to look at the tooth and look at the radiograph and see basically how deep that is. If it is very deep, if you got a blush, you got that sort of red hue that's showing, that's when you need the base and liner rather than putting an etchant. Again, the deeper you get, the more you should be using a self-etch versus a total etch, Now, this is 180% different than Burgess normally. I understand that, but the literature is showing that the self-etchers in deep dentin give you a higher bond. That's David Pashley who did that work, and Franklin Tay. So when you do that, you have a stronger bond. So the stronger bond is with the self-etchers deep. That's a nice thing with the universal adhesives, because you can use them in a total etch technique, a self-etch technique, or a selective etch technique where you just etch the enamel. But you really must etch enamel to get a good bond to enamel. Okay?
Great. Well, with that, we will wrap for the evening. So thank you, Dr. Burgess, for your time today. And of course, thank you to 3M for sponsoring this webinar. If anyone does have additional questions about the topic, or if we didn't get to your question, please feel free to email Dr. Burgess, or you can email us at webinars@henryschein.com, and we will route your question to him. Additionally, if anyone is interested in attending future Henry Schein webinars, please visit henryscheindental.com/webinars for our upcoming schedule. I would like to thank you all for joining us, and we look forward to seeing you back here on future webinars. Have a great night.
Thank you. Thanks, Adam.
Yep.
Bye now.